So I'm going to introduce myself here shortly, but I love playing music. I usually have a monitor if I'm playing in a band so I can hear myself. But if you just have house speakers, you can't tell. And I'm looking at you, and some of you are like deer in the headlights, so I don't know what that means, but I'm trying to figure out if you can hear me so you can hear me. It's a nice small room, too, which is great and intimate. I think it's Tableau's way of saying, this is my first time presenting, first time attending. So you're out of luck for coming in here. The doors are locked. You're stuck. But let's start early because, we're all in here. We're not going to have any more people coming in. My name is Luke Wilson. I am a medical informatics consultant at Priority Health. If any of you were at the last keynote with, is it Michael Lewis? Is that his name? Yeah. I haven't read a single one of his books. Didn't even know he wrote any of those screenplays, I guess. But one thing I took away from that is try to make yourself look dumb in front of people, make them look smart. And I am going to totally nail that today. So, but what I try to do, I work with many customers, mostly internal customers, strategizing how we can do whatever they need to do. So typically I work within interdisciplinary teams of clinicians and operational staff, from product development to strategies to improve health or to save money. Priority Health is a health plan, so we are the insurance side of medical delivery, although we do work and partner with our majority owned by Spectrum Health in West Michigan and Helen DeVos Children's Hospital. Anyone familiar with those names at all? A couple? Great. So how many in here are from healthcare? Excellent. So if I start speaking in acronyms and sound like a valley girl who doesn't want to text, then you'll be okay with that, right? No, I'll try to explain what some of those things are. You certainly are probably well aware of all the acronyms in the industry and maybe some of the unique ones in your field. So this is going to be a story time of a macro story and micro stories. We'll get into a little bit of how I built a couple of dashboards that I will highlight today. This is not a hands-on training. Some of these dashboards I spent many hours tweaking them, refining them to make sure that they maximized appeal, were repeatable, so that I could just let my hands off and run refreshes on the server. But I will definitely entertain questions. We could definitely go into the workbook. We'll be running right off of my desktop application because that works faster. I don't know if my web connection to my server back home will do it for me, which I do have there. So I'm just going to go right through this quickly, and then if you have any questions, I'll entertain them throughout the entire presentation. Just raise your hand or speak up. Hey, Luke. Hey, Giant. Whatever. Just call me out. But I want to introduce myself a little bit more. I do what I do because I have a really cool family. So that's me, the tall guy, because I'm just tall. And I look down on everyone, but not that way. My wife is fantastic. She called me, and she just wanted to support me. And then she said to me, she said to me many times, can we just sit down and watch a movie so I can cry? And I go, fine, let's watch a movie so you can cry. My oldest is Amanda. She's 11. She plays piano. Kayla's 9. She plays piano. And then we adopted a little boy, William, a couple of years ago. He was in the foster care system. So he's been a cool guy, and I'm going gray because of him soon. But he's fantastic. And a little more about myself. I love to make cakes. I don't know why. It just happened. So this is a cake that I made for someone. Go Blue. For my Michigan State fans like my wife, they would kill me for saying that. I really don't care, but someone wanted me to make them a Michigan football cake, so I did. I also love the Ford Mustang. And at work, I would bring in cakes for our little potlucks because we love to eat. And they knew I loved the Mustang, so they said to me, why don't you put them together and sell them? And I go, no one's going to buy these cakes. Plus, I really don't want to get into the baking business because I love what I do. But it turns out it became a website, cakesformustang.com. So I sold maybe 400 cakes in the last 2 years. And who knew that joke actually would come to fulfillment? Great. So that's a little bit more about me. Probably not what you were expecting, but that's who I am. And if you want to know more about me, pull me aside. I'm sure you'll be bored. So anyway, it's 5 o'clock. I'm very happy you're here. I was a little nervous. I didn't know if anyone would show up. They're going to serve dinner at 5, and you'd all get out of here and not want to be here. So, but this is a healthcare thing, and I love this proverb. It says a good laugh and a long sleep are the best cures in the doctor's book. So if you do fall asleep, it's good for your health anyway, right? So it's all about health. So I'm going to take you on a journey. I was introduced to healthcare in a very personal way. When we had our first child, we went to, for our checkup or her checkup to see how things are going. And when we got there, we came to the doctor, and he's got really bad bedside manner because he's smiling and telling us, I have bad news. And come to find out, my first daughter had kidney issues. She was born with 3 kidneys. So, in fact, the right kidney tried to form a third, and I'm not even going to the medical lingo because I'm not a clinician, and my wife is, and she could explain that better than I. So we had to plan out a really long surgery after she was born, and it took 5 hours, and it was nerve-wracking. Thankfully, we had a surgeon, a pediatric urologist from St. Louis, 20 years in the medicine, and finally retired. He was very close to us, and everything went well. So she's been infection-free and strong, plays basketball. It's been great. So this is how I sort of got into seeing that side of healthcare. I've worked at Priority Health for more than 10 years, and I'll explain to you what Priority Health is. So we, briefly, I'm just going to go through this. This is the most boring slide of all. Our mission as a health plan is truly to bring affordable care to members and improve their quality of care. And we started as an HMO, and HMO's always got that bad rap, trying to cut costs. But we are, in my way of thinking is we're like a Tableau of health plans. So I'm sure you feel the same way about yourself. I really do. We have a great knit family. We cover 600,000 people. We have many employers and offer individual coverage. We have a really extensive network. It's all based within Michigan. We'd like to just make sure everyone has great access to our physicians and hospitals. We also have excellent accreditation from the NCQA. Who knows what the NCQA is? Okay, a few of you do. It's the National Committee for Quality Assurance. Typically, the health plans will submit to get accreditation from the NCQA. Last year, I believe 484 health plans submitted themselves for approval or accreditation. 448 received their accreditation. Priority Health ranked at 41. So we love what we do. Love serving our members. So enough of that. Why are we here? So one of my former directors, he asked me when I first came into the team, I want you to look for something I've always wanted to find out is how do we save money on our prescription costs? And I don't know if any of you are familiar with the $4 drug program. You ever heard of it? So the $4 drug program is something that a lot of retailers have signed on with. There's a formulary of drugs that are approved for distribution at a $4 or less of a copay to the members and no cost to the plan. Now the member may get these drugs above the cost, of course, and then we pay out, but they don't know that exists. So my boss tells me, I want to see how many people are using these drugs, write a good SQL script to get the data, find out if they're paying a copay, this amount of copay for a 30-day supply or this for a 10-day supply or a 90-day supply, and then aggregate the sum of our paid as an opportunity because we can shift these members potentially to these pharmacies. So this is the display that I developed, and I'm going to toggle right over to the working view on desktop. What we see here are actually multiple sheets displayed. Some are floating and some are tiled. Don't remember the count on here. I believe there are 6 sheets, 6 working sheets. So we have a Pareto, we have a bar chart, geoplot, We have another aggregated total view. And then we have a couple of, no, sorry, we have 5 views. This is a floating worksheet as well. And then, of course, that's just a floating legend part of the Pareto. So what we're looking at here is, and who knows what a Pareto is? Raise your hand. All right, so some of you are like, I kind of know. So the Pareto, interesting point. The Pareto was invented, or the concept was created from the Italian economist Vilfredo Pareto. You would think he made Alfredo sauce, but he didn't. So in 1906, he realized the phenomenon that 80% of the land was owned by 20% of the population. So it became an 80-20 rule, which essentially says 80% of the effects are from 20% of the causes. So it's a good way of saying, you know, oh, that was bad. Okay. So this reference line here is 80%. These, what looks to be like an automatic filled line is not. These are all individual bars of members. And we're looking at this big red one here is the most expensive member in the year of 2013. So their annual cost was $767 in this drug of pravastatin, which is, and I'm not a clinician, so I had to make sure I knew what that was. But it's in the drug class of statins, you know, used for the treatment of dyslipidemia, that's what it is, and prevention of cardiovascular disease. So, there you go. I'm not going to go any further. So, what we're looking at here is this. This is another sheet as well. So I think I do have 6 here. This is the total paid for all of the drugs that were $4 drugs. Now, I need to stop right here. You know, we don't have products A, B, C, D, or E. We obviously have like Medicare and HMO, that kind of stuff. So this has all been declassified and sanitized, so you don't know what we're doing. And this is only for us to have a little playground in. But our leadership always wants to know, well, just give me the number, the big number. So this sheet right here just tells us the big number, which won't be manipulated. So anyway, going back to the Pareto, this is the best part, the focal point. So each of these members has striations, and you see we have 1,600 members that have taken pravastatin with a sum of paid of $245,000. I have since this is a dual axis, 2 views on here. We have a line, and then we have the members. We have the percentage of members add to the total cost right here, and we can see visually that about 50% of the members bring in 80% of the cost. I cannot stand in front of that speaker, apparently. So I have built into both views the same dialogue in the tooltip so that it's not confusing the user. So if I hover over that, we see 50%, again, of the members bring in 80% of the claim payments, or I can come down here and it tells you the same story, so to speak. And I wish I had their newest versions that haven't come out yet, where you can just move and it just shows you everything. But we're running from 8.2.2 right here, which is I think the latest deployment to all of us. So that's great. So we see of all these members here, this is where they distribute among the products, and this is the heat map of all those members by zip code. Our population mostly resides in Kent County and Grand Rapids area, which is where our home base is, but we serve the whole state. So here's the cool part. So you could say, okay, so 50% of the members bring in 80% of the cost. If you can do the math, you say that's 800 members, bring in, multiply this by a 20% discount to get your 80%. Well, rather than doing that, why can't let's just let Tableau do that. So we can hover over the item, and it'll do just that. It'll give us the member count of wherever I selected. I selected around 54, I guess, and it brings in a $200,000 paid for these members. So to get 80% of that cost back, I'd have to touch 800 members. And then if you didn't notice, this all updated as well, and the geoplot updated as well. So this gives us an opportunity to share this with multiple customers, marketing, executives. They may decide, okay, well, how are we going to touch these members? Is 800 members, we can't call all these members. It's going to be expensive. Maybe we want to mail them, but is that really what we want to do? I don't know. Maybe we just want to touch product A. That has the biggest savings. We could go with $88,000. Well, I already have this filtered, so this action, so I'll just click here as well, and it'll highlight as well where the members are at within the geoplot. Again, to keep telling the same story, this is also summed as well. You may not choose to have that. It's kind of redundant. It's already listed here anyway. So anyway, I'm going to move on to a second one here, just to give you an idea of how these Paretos work. So this is metformin, HCl. And you can see it tells a completely different story. So the Pareto falls well below the 20%. In fact, it falls right around 7%. Well, rather than trying to figure out what 7% of 625 is, we'll just capture them. Now it's very distinct. Maybe we can call 78 members since they all are spread out. We want to. That's probably the most effective way, but I don't know. Maybe we want to contact the PCP and say maybe you need to talk with them because they may have a mix of drugs that we don't know about. Because this is only talking about metformin. Again, we're at 94,000 in product A, so maybe we just want to focus on that as well. And it all updates. So again, the worksheet, all the worksheets try to work together to tell the same story, but then provide information that multiple customers from different areas in the company, internal customers, need that to make better decisions. So I'm going to pause right here about this dashboard and see if there are any questions. Yes?
Yes, so your action point from here would be basically that 66 members would be a call plan action plan or something like that?
Oh, what would the action plan be for those 6?
What are you doing with the dashboard? Trying to identify the 66 members to reach out?
Yeah, potentially it would be to, if that's what they wanted to do, is to touch those members. I mean, you can see that the slope drastically falls off. So your return on contacting all these members here is going to be few. So let me stop by saying also this is a proof of concept that we've developed. We haven't deployed it because we have a lot of critique we've been entertaining critique from our clinicians and operations. What are some pros and cons you see with this? I'm sorry.
Downstream costs to treat the patient, or where are you getting your costs from?
These are all claim. This is all from claim data, from claim experience in 2013
Okay.
for the drugs. You want to say something?
Well, would it make sense to kind of back up and see
Sure.
the Pareto plot, what drug was associated with the most payments?
That's a good point. I've actually already done that, and building this rink. So this is actually, we don't really need to visualize this for them. They may want to see it. I could produce that view, but really they need to create a strategy. If they want to see the total cost, they can see that up here, and then they can start drilling down. Once they get to maybe the fifth one here, the opportunity is only 71,000 for this, and it's spread out pretty far. But I guess it all depends on how many drugs you're dealing with. I mean, you see here, I pulled in all of them at 124, and if I just look at this last one here, I mean, there's really nothing there happening. It almost looks like a version of Donkey Kong or something. So, yeah, another question?
Yeah, just a quick question about deployment. I'm curious kind of what's succeeding and what hasn't. It sounds like this is you said, proof of concept. If somebody said, yep, this is great, would you then have to move to a monitoring view of this? Does that make sense? So tracking what happens after interventions or after certain policies, is that where something like this heads? I'm just curious how you're thinking about that.
Yeah, that's a good question. Before we get there, though, what are some pros and cons you see with this already? Maybe that'll help us. You have something else?
Yeah, well, I'm curious to know the feedback, especially in terms of the clinicians, and that I'm not quite sure who the consumer of this information is.
Mm-hmm.
I know one of the things I'm concerned about in my own business is you have all this information about consumers. As you start to mine that information, how do the doctors react? How do the patients react when you call them and going, what the hell, why are you all up in my business,
Mm-hmm.
my metformin or whatnot?
Sure.
So I'm curious if you've had end user feedback from, or which constituents you've had feedback from.
Right. So this has not been expressed or explained outside of our team or our internal customers. And I say customers all the time, so it's not external. We have our staff. We are a very skilled staff and kind of already can predict what they're going to think. The nice thing is we do know, I think in Michigan and also across the whole country, that physicians don't get kickbacks anymore. They used to for drugs. But you bring up some points that I'm hoping someone would just come out with some cons. What are some cons do you see with this kind of concept, Daniel?
Well, I mean, if I'm the patient, right, if I'm one of those 1,600, if you called me and said, hey, you're on this current statin, your copay is $30,
Mm-hmm.
I can help you if you go to the local supermarket.
Mm-hmm.
I'm going to save you $30.
Potentially.
20,
26 or 30, yeah.
You quantified that to me, and I said, okay, great, thank you very much. And now, as long as I know where to go, if I'm an elderly patient,
Mm-hmm.
it may even be helpful to direct them to the local.
So that's a pro that you're.
It's still pro. Well, if you added copay in there, you could actually calculate what the savings would be for the patient.
Oh, sure. Yeah, we'd have to, as an extension to that, this is mostly to understand the savings to the plan, which we then send on to actuary for them to determine what kind of percentage decrease could we potentially offer or reset for maybe some sort of strategy to market. Maybe we use the savings to market to an underserved community that we want to offer a product, or maybe we want to pursue a plan over here that we could share some of that savings with. I don't know. That's not for me to decide. Craig?
Do you have it plotted by the provider, the physician?
So I have the Pareto plotted by this.
Payer.
This is the plotted. These lines here are each member.
Right, I know, but if I knew, there might be 4 physicians that are prescribing 80% of that 107,000.
Yes.
You're on the inpatient and outpatient and ambulatory side too, right? You've got
Yes.
hospital charges, lab, pharmaceutical, and physician charges, right?
Yeah, but these drugs are only. So they're filtered to the formulary list only that qualify, which is really restricted, which could be dispensed in.
The physician is prescribing that.
Yeah, it's probably their normal regimen that they take.
You really want to change it, find those top 4 physicians that are prescribing that.
Potentially.
So you're saying you could intervene with 4 physicians instead of 70 patients?
Yeah, you contact 4 physicians and say, look, you're prescribing this.
That's a good point.
I'll send our pharmacist down
Yeah.
and talk to you about the way you prescribe.
Sure. So that's an alternate pro to the approach. Possibly, and Daniel had a good pro. Any cons though? I don't know your name. Sorry.
That's okay. One thought that occurs to me is if one of those members is on multiple prescriptions.
Yes.
And some of them qualify for $4 drug programs,
Right.
some of them don't.
Yeah.
Asking them to go to a different pharmacy is going to create more of a burden on them.
Yeah. That's a perfect con. Probably the number one I would think of. From the clinician standpoint, some of their feedback would be, if we were to encouraging them to go from Joe's pharmacy over to mainstream pharmacy that I'm not going to endorse in this presentation, and it's free or $4, we're only looking at the one drug. But maybe it's a little farther away. It's disruption of care. But we're isolating it to just this prescription. Are we recommending that the member actually just takes this one drug to the pharmacy and then continues using the other drugs at the other one? We also we don't know the quality impact right now. We don't. And this is a business analyst. We have to have our 10 antennae up, ready to sense out the flaws of this approach, or not potentially the flaws, but not coming to the quick assumption as you present $1.9 million in front of an executive who goes, let's do it. You gotta be careful. So of course, executives don't see this. My manager sees it, and he goes, okay, let's talk through it some more. But also, we're breaking their continuity of care. Are we going to ask them to go to 2 pharmacies to get their prescriptions? Have 2 pharmacists look over their prescriptions? I want you to go talk to Pharmacist Smith over here just to get this one free one, then continue getting it over here. Well, we might not want to encourage that, or we want to discourage that, so encourage them to go all over to the free pharmacy, well, the pharmacy that offers it for free. But we haven't considered the impact of all the other drugs. They may have a higher variation in pricing, and we may actually lose all that savings for that one drug. Daniel.
So if you could stratify the patients and then identify patients who only are on one statin versus patients that have multi prescriptions. If you stratified it, then that number would reduce and it would actually be a set that you would be able to go after easier.
Yeah, I think so. I mean, ultimately, I think this is still too naive of a concept. We need a lot more. We need a lot more data to provide the feedback. We need to know exactly what they're all on, produce variation in the market, produce some market prices for these other drugs, and see, okay, for the mix of drugs that they're currently using and the price that they get at these pharmacies, what's our aggregate total price for a dispense at this, and then the savings opportunity potentially. There's a bunch of hands I just talked over you, so I'm sorry. Go ahead.
Is that the sales on the drug that they are buying, or are they savings delta between the drug they're buying and what they're paying?
Are you referring to the Pareto or the bar chart?
Just the summation at the bottom there.
Oh, right here? Okay, so,
Bars.
oh, these bars here?
What's the measure here?
This is the sum of the paid from the plan.
On the drug that are actually...
On this current drug right here. So we have a total drug savings of $245,000, which the concept we might want to put it like right under here for, to make sure we're not making them look up and down. But that 245 represents all of pravastatin, and then it's distributed among these product types.
So it's a savings, or it's...
That's the sum of the paid, which would be our savings, because if they go to the $4 drug program, most they'll charge is $4, which would go right to the member, and we would not pay anything for those drugs.
So the 1.9 million is what?
The 1.9 million is the super aggregate of all of the $4 drugs if we were able to shift all of the sum of the paid over there. Not considering, again, as I said, all of the other drugs that they are potentially taking. And of course, drugs 1 and 2, metformin and pravastatin, are for our riskiest population with chronic diseases, and they potentially have a lot more they're taking. Yeah?
How do I describe this? One thing that I can see would be useful is the doc facility. Is that total out-of-pocket for the patient, or just how much Priority Health paid for?
Right. So none of this considers what the patient paid as a copay. It's what we paid, because it would be pure savings to us to ship them.
Right, so you've got claims data, but one thing you can also do, 1.9, you should have a comparator. I'd recommend you have a comparator to say, this is how much we paid.
Mm-hmm.
But the comparator is total number of claims times 4 is how much the total savings. There's something to compare it against versus a sum zero.
So you're saying that their copay should be taken into account?
To a certain extent, right? Because there's copay ranges.
Yeah. So I think I sort of said this, but maybe I didn't say it clearly enough. So I've only pulled in members that paid more than $4 because I wouldn't want to touch any members that paid less. And in fact, if they paid less, typically we wouldn't pay on them anyway. So my criteria included members at a 30-day refill paid $4, or on a 90-day, the drug program says they will only charge at more than $10 to the member. So I wanted to make sure that the copay the member was paying exceeded that amount, and that we also paid at least something on it. So that was part of my code to bring in the members. So I'm only looking at members who we would be interested in.
One of the cons you might have is you don't want to put this data on the member basis. And you're talking about going to computer ranges and quality scores. You lose however many prescriptions. That there's potentially some impact on that.
So you're saying that we wouldn't have those records because, right?
They're not going to get the point sales.
Exactly. So there's an issue that we have that as they bill them, there's a transaction fee for sending the claim over to us. So if they're not going to charge, why would they send a bill over to us to pay the fee to find we're not going to pay anything? Oh, we want to send you data. We love sending you data. We want you to send us data, but wish we could send it for free. Maybe we could just create a master Google Drive or something, and you can just send those over there. Who knows? But yeah, that's another. You can't measure the performance because chances are We'll still probably get them because that's the way they do it. But let's say that even 50 or 60 or 80% of them don't. We don't know the impact. That's a very good point. All right, I'll entertain a couple more because I probably need to move on because I know some people are like, well, I started early. We want to get out of here early. But go ahead. Who raised their hand? Yeah.
Do you roll other costs into the application besides just
That,
money on
right.
this drug is making a difference? That's
Right.
what try to say downstream. I mean,
Yeah.
disclosure, I'm a health economist, so I'm
Yeah.
just looking at all this.
Yeah, so like I said, this does not take into account the mix of their drugs.
Yeah.
It only takes in that one. So,
This is like within priority health, these are the changes you make. This doesn't influence like healthcare as a whole, like trying to influence the cost to society.
Correct.
It's really just almost, it's accounting, sort of.
yeah, we're strategizing to accrue new savings so that, again, we can help the member potentially. And that's the end goal. We want to help the member reduce their burden of the cost of care. But we also don't want to reduce the quality or create inconsistencies, which then reduces their experience. So, was there another question?
Just wanted to figure out from Mel's question. Who's the actual, you understand who the influencer is here? I mean, if you're going to go to making a call or whatnot, you're going to call the doctor, or you're going to call the end customer.
Mm-hmm.
And depending on what the answer to that is, I would recommend that you group the total drugs up by that node and figure out a level of effort for a phone call. That costs $25 a phone call.
Sure.
And you have a conversion rate will cut it.
Sure.
It actually run as a control line or something.
Yeah. So I think that goes along with maybe some of the conclusions I would make with this is, this is a starting point to get us talking about the drugs, but we need to have an understanding of the total cost for each member and aggregated to the providers to find out what kind of impact, maybe a Pareto by the provider, and maybe if we preferred that, if that worked. But I need assistance from our provider performance groups. I need assistance from customer service, other operations, including our clinical staff, to help us, and marketing, to help. I need their subject matter experts to figure out what's the best way to get the ROI we need with minimal cost. So, but I'm going to move on, and feel free. We can go back at the end of the session. I don't want to keep everyone here waiting. Okay, good. I clicked this left and right and feared I was going to miss that. So, taking on this journey, we know that Tableau is a great way for us to gain perspective. So, one of my favorite quotes is from C.S. Lewis, and it'll get there eventually. That's terrible. There we go. Okay, never mind. There you go. So what you see in here depends a good deal on where you're standing, and you can easily come to a conclusion within Tableau if you're a novice analyst and drop a couple of fields in here and you go, oh, I see opportunity. But you need to have the critical business mind and know more about what your data, where your data is coming from, and the members and what's underlying your data, the cultural assumptions as well, maybe operationally how it gets there, and then provide more visuals. So that's the attempt within that to show with the previous visual. We have a Pareto, we have a bar chart, a geomap, and it helps to provide some perspective as opposed to just a bunch of bar charts or a bunch of line plots. So I'm going to fast forward to the baby of mine. This is something I've been developing for the past 2 years as a passion area that actually started 6 years ago. I worked in operations as a pricing analyst, not really the business analyst that you would think we are all, data analysts, where I set up the contract prices in the system and audited them prior to them being implemented to make sure that what prices the contractors and the negotiation and the hospital system negotiated actually happens in the claim system. And so I set them up, and as I'm setting this up, I'm seeing this wide variety of pricing and schemes and case rates and per diems and fee schedules, and you just go, what's happening here, and the member doesn't even know what they're going to be billed for once they go in for services. So I'm going to briefly describe before I get to the visual. So my passion was to find out a way that we could disclose and provide transparent pricing, or make it transparent to our members by creating pseudo market values for all of the codes that we get billed. You can't go to the, you go to the restaurant, you see what's on the menu, you see the price, the lobster tail is $81. You know if you buy it, it's going to be $81. But when you go to the hospital, you have no idea. There was a Diane Sawyer report a couple of years ago following some family where the cost of treatment at one hospital is $3,000 and they could have received it for $1,200. Well, they had no idea. Well, the member doesn't have any way of really going there. I mean, there's some projects that I know you probably have worked on as well, and that's why you're here, to hopefully gain some of what we've done, and I'd love to hear some of your advice too. But my hope was to create a relative pricing, market pricing system or value that could be dynamically created through our data sets. So it would take place of service into account, or at least where the member got the treatment, if it was in the facility bill or a professional bill, what product the member was in, within what region or sub-region they might be in, the intensity, so taking modifiers into account and the number of units, and trying to establish some sort of market value based on a retrospective set of data and reimpose those market values as an aggregate, or whether it's a median or 40th percentile axis within those accessible providers, and then reinsert them into my master data set, and then the difference between what the paid amount was, or the allowed amount was, I guess, to what the market value is, we could suggest savings. Still, we don't know how to get this to the member because they really don't know what some of these services mean. So you try to create friendly terminology. Yes, go ahead.
I was going to ask you, how do you contextualize this with the fee-for-service program?
Yeah, so here's a good example. Yeah, great. I kind of skimmed over this. So who knows what case rate payments are? Awesome. I really don't want to lose you on this. Who knows what fee-for-schedule payments are? Okay, so a lot of you need to know this real quick. So when a claim comes in, based on the contract, they may have what's called a fee-for-service model. So every claim line that comes in, if it comes in with a certain code, it comes with a certain modifier, whether it's an informational or it's a modifier that provides a reduction factor or it increases the value. For example, a member comes in for some sort of CT scan. Well, it may present with this code with an LT modifier, which is left. Or it may come in with no modifier, which typically could mean just one side, or it could, if they build two of them together, could be a bilateral. Or they could build that one code with a 50, which is a bilateral, which means they did two chest scans on one line, or left and right scan. And then, and each line would get a reimbursement value based on what they build. There's also case rate payments. These are kind of the big ones, where the claim would come in with maybe 10 lines, and we would say, oh, we see this big code up here. This is the surgery code. Well, per our contract, we're going to pay $2,000 on the surgery code. All the other lines are going to get no payment. So we don't care what you did. What's that? Well, for DRGs, like for an inpatient stay, this is similar to, let's say, APC methodology, too, for outpatient services, which is, I'm not going to go down that road because I don't want to lose any of you if you are being lost already. But the point is, majority of claim payments typically in the professional world, let's just stick with professional claims, are paid by line items. So it's kind of like when you go to the grocery store. You buy a thing of milk, you buy some cereal, you buy grapefruit, whatever. And you're going to pay a certain amount for each one of those items. Well, imagine going to the grocery store and saying, I'm going to get some steak, and I'm going to get let's say you got steak on that other one as well, I guess. But you're getting steak, you're getting milk, you're getting cereal, and you're getting your grapefruit. But the steak was on your receipt. And you have a personal relationship with this store that if you buy a steak, you're only going to pay this amount on your bill. So your total charge on your receipt is $150. And let's say there's some sort of addendum that says you can only get 10 items in total. So then, for all those 10 items, you paid $150 regardless of what you got on there. So how are we going to connect these services with no allowed amount? They have zeros. So that gets me into methodology, which I don't really have time to get into, but I weight this case rate payment across all the lines, and I re-inject it based on a relative average to their build amount and allowed amounts of it's an algorithm that I've been developing, and it re-injects the price that would be there. So for example, that $150, or let's say you go to surgery again, that $2,000 surgery, and it had 10 lines, based on the build amounts in the claim, I'm going to redistribute that price across all of those to sort of inject a price for that. Again, there's some flaws with that, but that's the best we can do. And then I'm going to compare those values back to this market set, data set that I've created based on experience. Anyway, I'm not going to talk any more about that because this is getting too far and you want to see Tableau. So I've created what seems to be rather simple compared to the other one. I'm going to jump over to, just froze on me. All right, so I'll jump over to the visual. So this dashboard isn't going to the members yet. We don't quite know how we're going to get this terminology out to the members so they can understand their costs. But we're working on deployments of that, but we're trying to figure out kind of where the pricing is for the providers as we then decide how we're going to communicate this to the member. So this would be more, my audience again is going to be internal. It's going to be for contracting staff for them to determine, okay, what are some of our high-priced services? You know, they might have an idea of what services were rendered in some sort of time span, and make some assumptions based on calls in the call center. But this takes all of their claim data retrospectively, and this we're looking at, like, say, 2013. Again, all fictionalized. There is no Gray Sloan Memorial Hospital. Actually, there is. It's kind of a dramatic hospital, so they have a really high value. There's some others in here. Greenacre Memorial, that's a fantastic one. They're not as efficient. But what we're doing here is another heavy aggregate. We're looking at product A, $21 million in average annual avoidable spend. This is a heavy aggregate of the differences between the market value, or the allowed amount that we suggested, or the allowed amount that we may have suggested, and the allowed amount or on the claim, to this market value that I've reimposed to its region and all the other cohorts. I've created this list right here, which then provides that aggregate measure for each of these hospitals or physician organizations with a parameter that gives us the top N, which we can select, and these right now is showing 30. I've created a dynamic sort, so I could sort this by average annual avoidable spend, which is these bars here. Or I could sort it by the avoidable percentage, so it changes the sort and then sorts on that. But you probably want to keep it on the heaviest spender and sort it down. So what does this mean? What we're just saying is, for Gray Sloan Memorial, it gives us a script that I've put in there. It says for under product A, Gray Sloan Memorial is ranked number 1, sorted that way that we said, with an average annual avoidable spend of $2.2 million. And this is an update I wish they would have. You could just stay there, and it stays. And an average annual medical spend of $2.2 million, or 24% waste in their system. So then I provided a filter by menu, because I don't want to just click on this and find the person not knowing what they're doing, because this is kind of a heavy tool. I'm going to select this, and we're going to say, see the quarter detail. So then it produces kind of a time series for that data, broken into quarter to kind of produce a trend and to see how it's performing. It may suggest that it's going down, but it's pretty much flat. And depending on how the market was doing, if we were losing members or gaining members in a certain time period, it may go up or down. So the access of the service may actually change the volume. But at this point, it doesn't really tell us much. A new legend appeared to show us what those are. They weren't there before. Still displays that we're looking at Gray Sloan, the product. But let's say I'm interested in this quarter, and it gives us some of the same detail we saw in the heavy aggregate, and I want to see the code detail. So now we're getting into the weeds. And we're trying to show the contractor what it is that you potentially could do to help negotiate and reduce the costs. So we have this injectable here. Again, it's similar parameter as we saw up here with the top N. So the top 25 codes sorted by the average annual avoidable price, kind of similar to this. I haven't provided a dynamic sort because it's kind of irrelevant, as we saw. And this gives us, again, something similar. Displayed something here that probably I wouldn't recommend. Can you notice it in the tooltip? The data.
The options to keep excluding the data behind it. Is that HBI in there?
I'm sorry?
Is HBI in that data?
Is HBI in the data? No. You're going to have to clarify what you mean by that. Oh, no. This has all been sanitized. This is none of our real information. We're not contracted with the Grace Sloan Memorial Hospital. So, no, so what I was going to say, and this is a subtle one, I'm a stickler for, and I think it's, or stickler to this. We have the average annual medical spend of $442,000, and the average annual avoidable spend of 0.2. We're looking at two different formats here, and it's really hard to tell. It's really 200,000. It could be 240,000. It could be 200,000. But then we see that we're looking at 56%. So I would change that to make sure. Some of these are already working in millions, so just make sure that you keep formats that are relative to the size of the data you're looking at. So then this is the best part. So I don't want this dashboard just to be attractive and cool, and it drills down. This is obviously a drillable dashboard. That's what we're doing here. And I selected catheters, which I don't want, cath placements. So I'm just going to unselect that. I'm just going to stick with this injectable code. So what it's telling us is it pops up a title that says actionable details. So this is the window that I want. That should be the most important, and it looks silly. It's really just a bar chart squished into the corner. But the juicy part is in the tooltip. And this is where the contractor could potentially go, okay, so what do I need to do with this code? Or what could I do? And so the model is suggesting that for this code, the average medical spend per unit was $232 or 45 records, where the market allowed was about $94. The difference between the two has already been computed in the tooltip, so it says the difference is of $137 in a shift. If we was contracted at a pure fee-for-service model, and that was an option, I'm sure that the provider would love to see a drastic change like that. But if we could achieve that, based on the utilization that we've had in the prior year, or on average, it's going to produce a savings of $152,000. Now, at first glance, you might go, how are you getting $152,000 out of just 232 on 45 records? There's only 45 of them. That doesn't make sense. Well, those 45 records have hundreds of units built on them. So they're not built at 232. They're built in thousands over those records. So again, you can do this for any one of them. One little nice thing I've done here, if I go back for aesthetics, I like the legend to help tell the story. So you can see this gradient stepped legend is synchronized with the colors here to show, for reference, where we're at. I capped it out at 40% because it's not meaningful. I would think that anything beyond 40% should all be red. Let's say you could change it if you wanted to and re-step it. Just make sure that it just kind of syncs up. I'm floating this, so I just sized it sideways to make sure it kind of matched up. So, any questions about this or the concept? Yeah.
Awesome tools for that's obviously calculated fields or bringing the sentence structure.
Yeah, it's mostly calculated fields all working together. None of these use window averages, which are some fantastic calculations as well. Gotta be tricky with those. Test them if you don't know what you're doing. But yeah,
A lot of R in your calculations, or using most of the table?
just using the table. So my hope is my dashboards will require little support, provided that they're vetted and secure, that that the user is not calling me up and all the time saying, what does this mean? What does this mean? But they can also look at it, and since they dig in the trenches with this, they know these contracts better than I do. I'm trying to let the data tell the story. But they can go in and say, well, I've got a problem with this. This market value doesn't seem right. And my hope is I can provide them information that they can say, oh, let's just double check our contracts. Yeah, he's got it nailed, or it's pretty close. I'm not trying to get it on the bullseye. I'm just trying to get it close to that bullseye. All right, so again, I'll entertain questions if you have any. So we're happy that that we've positioned ourselves to be a champion. You know, we're number 41 NCQA. We're about savings, but we're really all about giving members access to affordable care, and we continue to strive for that. But the problem is, you may know if you're in healthcare, is as you try to provide affordable coverage to your members and reduce the burden of care and provide greater access, you're also dealing with strategies from the physician side that are also trying to grow their practice, provide more assets, so new cardiologists or new specialties, which incurs more costs, and they need utilizations to support that strategy. So we're at a conflict that you all probably are well aware of. So transparency is not something that's easy to swallow nor easy to create. So it's like trying to create 10 omelets right now with one hand and like one spatula. So that's a terrible analogy. So anyway, this is my fun little visual. Tableau has energized our efforts and hopefully yours into our exploration of new great ideas. And just when you think you've hit the peak, you realize you've got so much farther to go. So I'm happy to take you on this journey. I hope it's been added value to the session. I was kind of, like I said, I was nervous, 5 o'clock. No one wants to be here for a session, so I really hope it added value. And last but not least, make sure you do go and do the survey. Anyone like in the top 20? Okay, they're not going to tell. They're too modest. Oh, we got one over there. So I am done unless you guys have any questions that you want to. Yeah, and I'm here if you want to ask me anything else. So thank you very much.